Hello? Hello? Is it working now? Kindly switch off your mobiles. Thank you. Good evening and namaskar to all of you. I welcome all the audience here who have joined us physically in this particular hall. And I also welcome all the audience who have joined us on line through Zoom or through YouTube. And I also welcome my panelists, that is Professor Atul Ambekar, Professor Gangadhar, Dr. Koushik on my right side, and also three speakers who are there online with us Professor Srinivasa Murthy, Professor Pratima Murthy, and Dr. Andrea Bruni. And you all know that we have assembled here to discuss the launch of World Mental Health Report 2022. But before we come to the actual presentations by each of the speaker, I would, thank you. I shall briefly reiterate why it is important to discuss mental health in the present context. Mental health has remained important, but at the same time neglected area for many decades, and it still continues to remain a problematic area. Mental problems can cause significant burden and disability. Even now, we are not fully equipped to deal with them in view of the huge gap between the demand and supply. And there are multiple barriers to mental health care. In spite of the fact that it has been documented that for a nation to progress and prosper, it is not the finances or the per capita growth or GDP, it is the investment which a country makes on the mental health of its population. Last 25 years of the last century have been very crucial in mental health development in India and as well as all over the world. Some of the highlights of Indian development of mental health, that in 1974-1975, Professor N. Wig, who has been a guru-like figure for many of us in the Indian psychiatric scene, he attended the WHO meetings about the extension of care on and organizing of mental health services in the developing countries. This led to, in 1977, PGI Chandigarh, that is Postgraduate Institute of Medical Education and Research Chandigarh, in 1977, PGI was designated as the WHO Collaborating Center for Mental Health. In 1980, Professor Wig moved to AIIMS New Delhi, and where he, in August 1982, he and other experts of mental health, they drafted the landmark National Mental Health Program, which was the harbinger of the subsequent district mental health program. And now the district mental health program has covered most of the districts of the country, and we will hear some more about it from Professor Pratima Murthy. Subsequent to that, in 1984, Professor Wig moved to EMRO, that is the Eastern Mediterranean Regional Office of WHO, to look after the mental health of 27 countries, including Pakistan. Meanwhile, Professor Srinivasa Murthy, who is a panelist here with us, he also moved to NIMHANS, that is National Institute of Mental Health and Neurosciences, Bengaluru. And you know that NIMHANS is an institute of national importance. And where he started the internationally famous Billari project. And subsequently, because of his work in the community mental health, WHO drafted him as the chief editor of its first ever World Mental Health Report 2001. And we'll know about the background and the scope of that report from Professor Murthy himself. Internationally, some landmarks development took place. In 1996, many of you would know that the global burden of diseases was launched. Now, this was the first time that the burden was quantified of each illness. And it was also, this report also documents that how you could quantify disability also. So, what was significant from this report for mental health, that mental health disorders, the disability or the burden caused by them, were not insignificant as compared to other well-known illnesses like cardiovascular illnesses, cancer, or respiratory diseases, that they were causing significant disability. At the same time, the projections of the global burden of diseases was that by 2030, depression and related disorders, they would occupy #1 position as far as disability was concerned. And already we believe that depression and related disorders have already occupied #2 position, and the COVID has resulted into so much of damage here. Then in 2000, the World Mental Health Atlas came into being, and the architect of which was Professor Shekhar Saxena, who rose to become the Director of Mental Health Division, WHO Geneva. Then in 2001, Institute of Medicine, United States of America, came out with another landmark publication, that is Neurological, Psychiatric and Developmental Disorders in Developing Countries. So a lot of focus was being done internationally about the mental health care in developing countries, because what was being seen and documented, that the burden and the disability experienced by the developing countries was of such magnitude that they were ill-equipped to deal with that burden. So with the limited resources in terms of finance, manpower, and infrastructure, how the extension of services could be provided to people who were underprivileged and unreached. Then 1990, it was declared, that decade was declared as the decade of brain. And also at the same time in 1990, Human Genome Project was also launched, and that led to significant advances subsequently in the neurosciences. All these reports and publications were sharp reminder to us that significance of mental health, the barrier of stigma, manpower, lack of penetration of services to the unreached and underprivileged was significant, and we can't just neglect them. Like these last 25 years of the last century were important, the first 25 years of the current century are equally important. And it is not just because of the COVID. There are multiple things. For India, a number of things took place in the last 20 years or so. One is that there was escalation of mental health budget by the Ministry of Health and Family Welfare, because of all these evidence which came that the investment is required for extension of services to all areas which have remained uncovered so far for mental health care. So the district mental health program has been expanding, and we will know about it in detail subsequently. Then in 2014, this is the first time that National Mental Health Policy was drafted and released by Ministry of Health and Family Welfare. It so happened that we had number of things, but till that time, India did not have National Mental Health Policy. So that was the first time. Then our Mental Health Care Act, or Mental Health Act, which was last revised in 1987. 1987? It was again revised, and it came into its current form as Mental Health Care Act 2017 by Ministry of Health and Family Welfare. Then National Mental Health Survey was launched by the support of Ministry of Health and Family Welfare by none other than our Professor Gangadhar at NIMHANS, and he will tell us more about the findings of this survey to tell us that what is the kind of disorders which are present in the community, what kind of care is available, and what is the penetration of services. Then in 2019 came the report of National Drug Use Survey, and the architect of that survey was Professor Atul Ambekar, who was the principal investigator, and some of the other co-investigators are currently present in this hall. And he would tell us about the salient features of that survey. And then, of course, in 2022, we had the launch of World Mental Health Report, and Koushik on my right side, and Dr. Bruni, who were joining us virtually, he's already there. They would tell us more about this. And subsequently, that would end with the vision of Ministry of Health and Family Welfare about the mental health care, and Professor Pratima Murthy would tell us more about that. So with this brief introduction, I would come to the panelists now. The first member to address us this evening is Professor Srinivasa Murthy. Professor Srinivasa Murthy is the ex-professor and head of Psychiatry at NIMHANS, Bengaluru, and also Dean of the same institute. He is former WHO consultant and chief editor of World Mental Health Report 2001. And more than any of such things, he has remained from PGI days my friend, philosopher, and guide. And I always look upon him for any kind of advice, support, and to sound him for a number of things. So, Professor Murthy, may I request you to tell us about the background that with which WHO came out with its first mental health report in all these years. Never before we believed that the WHO had come out with that kind of document. So tell us about the background and with what vision. Over to you, Prof.
Thank you, Sudhir, and the fellow panelists and all the distinguished participants. It's a very special privilege to be able to share with you the background and the content and the impact of the World Health Report 2001. Can I have the first slide, please?
Slide.
What is very important is that the World Health Report is in 2000 was an annual activity of the World Health Organization, and every year a different topic was chosen by the World Health Organization. In point of fact, it is very special that 2001, it was called the World Health Report 2001, focusing on mental health. In that way, it is very different than the 2022 report. Next slide, please. But this report has to be seen, next slide, please. This report has to be seen in the context of the leadership of WHO in the last 50 years. Already, Dr. Sudhir has referred to this particular organization, which is very special because it was almost the Gita or the Bible for all of us working in this area. And luckily, I was in PGI Chandigarh when Professor Vick returned from this meeting of 1974, where he was the rapporteur, and this report came out. It made three very revolutionary recommendations. One, every country should develop a policy of its own. The care should be not in institution, but in the community. Much more than that, we must think of deprofessionalizing, despecializing the services so that everyone from primary health care onwards can provide this care. What happened, next slide, please. What happened after that was very dramatic. Number of countries came up with national plans. India was one of the first to do that in 1982. Then Pakistan in the early 90s, Iran, number of countries literally developed a program of their own. So all this was happening, and Dr. Brundtland came into WHO as the Director General of Health Services for a personal reason as well as a professional reason. She said mental health should be a priority. The year 1999 was full of series of workshops and seminars in WHO to look at mental health, which culminated in a decision that 2001 report would be only on mental health. In addition, the World Health Day of 2001 would be devoted to mental health. This has not happened in the history of last 75 years history of WHO earlier. She said a very passionate thing. I mean, it was a pleasure working with her. For me, we have the means and scientific knowledge to help people with mental and brain disorders. Governments have been remiss, as has been the public health community. The second force was, next slide, please, Dr. Seracino, who was a dynamic person. He was the leader of the Nations for Mental Health in the 1990s. This is the wake-up call for all of us, for the world. The current situation paints a dismal picture of neglect and a severe lack of resources. The sooner we face up to this reality, the more prepared we will be to provide care and cure. I think this was a very strong statement about the need for action. Next slide, please. Luckily for us, all over the world, there was focus on mental health. Sudhir has already referred to the Institute of Mental Health report. Simultaneously, in 1 year before that, the Surgeon General of USA released a 500-page report where he noted nearly half of Americans do not seek treatment. Stigma attached to mental illness and to people with a mental illness is a significant barrier. So mental health was seen as important at the end of the last century. Next slide, please. So the year 2001, the April 7th World Health Day was on mental health. All over the world it was done. There was a children's painting competition. Again, interestingly, a child from Delhi got the first prize, brilliant picture. And the theme was Stop Exclusion, Dare to Care. In October 2001, the report was released. As you see, it was a World Health Report 2001 with mental health as the things. And the message that was given was that there is new understanding. So there is new hope for the population in general and mentally ill person in particular. Next slide. What was the issue? The preparation of the report itself was a long process. It was a 2-year-long process. We had an advisory committee with Dr. Sartorius, Dr. Leon Eisenberg, Arthur Kleinman, number of eminent people, and all over the world. People sent us documents, reports, saying that these things should be there. You'll be surprised to know that a full-time 2-year representation was there from NIMHANS. Tom was there with us in WHO to give inputs into it. So it was seen as a worldwide activity. In the activity, this slide is very, very important. We had a lot of discussion. Should we talk about mental health or should we talk about mental disorders? The feeling that we got was that at that particular point of time, it is important for the world to look at the mental disorders as priorities and services as important. Not that mental health is not important, the left side of the graph of distress and unhappiness, but for the present, it was decided, and I think time has come for us to now go back to the left side and make mental health the issue. I'll come to that in a minute. So the decision was to focus on services that was very relevant to developing countries particularly, and also developed countries, as you would see in the presentation. Next slide, please. There were two major focus of the report. It's a 100-page report, half of the current report of 2022. What are the core actions to be immediately taken to improve the health situation in the countries? And how can individual countries develop this? Next slide, please. And again, there were 5 chapters besides an overview: public health approach to mental health, burden, solving mental health problems, mental health policy, and way forward. There were 10 recommendations. Next slide. There were 10 recommendations. 5 of them were related to services. As I said, the focus was on services, provide treatment in primary care. This was revolutionary. Today it's accepted easily, but at that time it was very revolutionary. Make psychotropic drugs available at primary health care, give care in the community, educate the public, involve communities, families, and consumers. There were 5 supportive actions to be taken: national policies, programs, and legislation, develop human resources, link with other sectors like education, welfare, judiciary, labor, monitor community mental health with indicators, and support more research into the cause and outcome of mental disorders. So these 10 were there. But at the point is that we had a big problem. How do we present it to Somalia versus America? So what we did was, next slide, what the group did was to come up with this brilliant idea: scenario 1 for low-level resources, scenario B, medium-level resources, scenario C, high-level resources, as a chart at the end of the recommendation, so that will be an action point for every one of the countries had something to do in this area. Next slide, please. What happened was very remarkable. I'm sure you will hear a lot about it from Dr. Koushik. National programs came up all over the developing countries in a big way. Mental health in primary health care became a reality, and the WHO put in a lot of money into the mental health gap program to develop educational materials, indicators, all of these things, and legislation, as Sudhir pointed out. India and other countries revised it. Human resources have increased enormously. Just let me give you an idea. In 72, when I took up psychiatry, I had to move from Bangalore to Chandigarh because there were only about half a dozen centers with about 30 seats in the whole country. Not even Madras, Vellore had training programs. Today, we have something like 1,000 postgraduate seats with about 250 centers. It's a remarkable. So human resources have increased. Innovations in mental health care is enormous, and the WHO 2022 documents it very well. More than that, we have after the 2006 United Nations right for the disabled person, consumer activism. So lots of things have happened. You will hear about it from Dr. Koushik. Next slide, please. I come to the end of the thing. Much more information. You can see the progress of the last 20 years with the mental health atlas. Again, Dr. Saxena was the leader, and we see a significant progress in all the developing countries as well as in the developed countries. Next slide, please. But there is a problem. It was Dr. Saxena, when he was the director of mental health in 2018 or so, said, when it comes to mental health, every country is a developing country. This statement is very important because Dr. Thomas Ensel, who was the director of mental health with about for 14 years with about $20 billion, has written this book released in February 2022. He says there is a crisis of mental health care in America. Majority, 90% of the mentally ill are in jails, and number of things. He talked about there is need for us to rethink our path from mental illness to mental health. That is the place where we are in, and I'm very glad to say that we are today in a position where we can address mental illness as well as mental health, and you'll be hearing about it from other speakers. So I want to conclude by saying the World Health Report is a reflection of the will of the 200 member states. It is a will of the knowledge that is at that particular point of time. It is a will which shows the direction in which it should go. And I felt privileged to be part of it for during those 2 years and to see the developments in the next 20 years. Thank you very much. And
thank you, Professor Murthy, for taking us through the journey of development of World Mental Health Report 2001. Because what you have said that currently India has close to 10,000 psychiatrists in the country, and every year we are producing 1,000. When the National Mental Health Program was launched in 1982, it was considered a very ambitious program because India had less than 1,000 psychiatrists for its population. So people had wondered that what kind of program we are going to launch with such limited number of mental health personnel. But India has made rapid strides, though we have not reached the very ideal position, but still we have come a long way. Thank you very much, Professor Murthy. In terms of what kind of disorders we have in the community, how many people are suffering from those disorders, and what kind of care is available in the community, Professor Gangadhar and his team at the NIMHANS, they conducted the National Mental Health Survey, and its report came only a few years earlier. And may I request now you, Professor Gangadhar. As I said, Professor Gangadhar is the Padam Shri recipient. He is the ex-professor of psychiatry at NIMHANS, and also it's the former director, and he has been a close friend for last many decades. You, Professor Gangadhar. Yes, please take this.
Let me greet all the fellow panelists and the audience. I'm happy to be here. While I may not share slides, but I will quickly give a glimpse of what this National Mental Health Survey in the background of what is the extent of mental illness in the community and how we can look at this data and where we are going to move forward from here. Mental health prevalence has had a long history. There have been several field surveys in the past. The numbers have been different across different studies, and this led to a confusion, if I can call it so, although it's not truly a confusion. The numbers, absolute numbers were very massive, but if you go by the prevalence rates, figures differed across studies. The predecessor of this National Mental Health Survey was yet another large multi-center, multi-country World Mental Health Survey, which had some data to share, to tell us although it was planned in the early part of this century, the work, since it was a multi-country research and a very detailed evaluation of patients happened with a different instrument. The diagnosis was made with a very standardized instrument. India was another center where the study also took place. While the figures were reported, the full project report came a few years before the the National Mental Health Survey report was announced. It is interesting to note that the close to about 14% of our population in India and about 18 to 20% of the population in some of the developed countries had psychiatric illness and required attention. So this was, of course, may not be seen as a truly representative in a statistical design, but nonetheless the figures it has given appears quite alarming. The number is quite huge, and this is the population which needed attention. In the background of this, the work had begun in our country to launch a nationwide survey. Very important identified researchers in epidemiology and mental health put their heads together, and NIMHANS was the collaborating center, and my senior colleague Dr. Gururaj was at the helm of affairs, and there were multiple other mental health and statistical as well as epidemiological specialists who added their wisdom into the design of the study. The population was identified to be representative of the entire country, representative of as much as possible both rural and urban, representative of different regions of our country, and it was based on small multiple levels of stratification, and finally the data of about 35,000 population was investigated. This 35,000 population represented close to about what could be seen as this 35,000 was representative of about 70% of our population, reasonably representative. And the investigation was launched and the figures were obtained and a detailed report was prepared, and in 2016 World Mental Health Day, the final report was submitted to the government. Some of the observations, some of the efforts that were taken in terms of preparing this document or preparing this research included not just measuring the prevalence of the disorder, but also to look at some very key elements: suicide rates, special population like children, although the population in children may not be seen as necessarily representative, but it also included children, and it also included the what were the services available in the state, how the country was prepared to address mental health conditions, and of course the cost that was involved in treating an individual. So multiple variables were also looked at in the survey, as against the World Mental Health Survey that had recently been completed. So together the results were of course not very different from the World Mental Health Survey, but nonetheless there was differences. The mental health prevalence was about 10%. The values for severe mental disorder, if you take from that, were much smaller, 10 times smaller. But nonetheless, the prevalence of mental health conditions was close to 10%. What is important here is that there were some urban-rural differences, urban being higher than the rural. The figures of mental health, National Mental Health Survey also indicated that the amount of expenditure that a severe mental disorder caused was much higher than the common mental disorder in terms of treating an individual in the community for the family. The National Mental Health Survey, if you see the results, and if you see the World Mental Health Survey report, and the overall prevalence of the disorder, and what in the context of the World Mental Health report that has now been released, I want to draw your attention on one of the issues, that the prevalence rates in our country, even by the World Mental Health report, World Mental Health Survey that had reported, 14% in our country, about 18 or 19% in the developed countries, is one component. Of course, our survey showed even lower prevalence of about 10%, the National Mental Health Survey. But the fact I want to bring it to your attention is, in the World Mental Health report, some of the disadvantages to our country that have been pointed out include, of course, poverty, fewer psychiatrists that were available. We heard Dr. Srinivasa Murthy saying that the psychiatrists that were available way back in 72 were very few, and even in 82, when the in the National Mental Health Program was being thought of, the numbers of psychiatrists available were fewer, and the numbers of places where the psychiatrists were being prepared for slowly has increased. Of course, now we have about 1,000 psychiatrists being prepared every year from different institutions. It has grown though, but time and again, various bodies have been emphasizing that psychiatrists and psychologists are a lot fewer in our country compared to many other developed countries. So, poverty, fewer psychiatrists and psychologists, fewer beds that are available for psychiatric care in the country compared to other countries. And we also had, of course, other social issues related to stigma, which of course existed elsewhere, but stigma is another thing that we perhaps have to factor why our treatment seeking is perhaps low, which is also reflected in a huge treatment gap in the National Mental Health Survey. That was one of the issues that we talked about, was a huge treatment gap, close to 75%, compared to elsewhere in the world, in the developed countries, the figures was in single digit. So a huge treatment gap, fewer psychiatrists, poverty would all be seen as factors which would actually lead to higher prevalence of mental disorders, and these were considered as what would be contributing to higher prevalence of mental disorders. What was another aspect which the National Mental Health Survey brought out was a very high prevalence of suicidality and suicidal thoughts, which is very high. In fact, World Mental Health Survey and the National Mental Health Survey put together, we perhaps account for 1/3 of all the suicides in the world, whereas our population accounts for only 1/15 or 1/20th, 5%. I mean, 20% of the population is represented by our country, whereas 30% of the suicides seem to be happening in our country. So this is one concern that we probably have to take very seriously. Whereas when you take into account mental health disorders, where the prevalence rates described about 10% in the National Mental Health Survey, we about 5% higher in other developed countries, we look at the risk variables that have been projected. Fewer psychiatrists, availability of medicines across being lower as reflected in a large treatment gap, and of course poverty, which could also contribute. Looks like these contributory factors could well adding to our prevalence disorders, but there could be several other factors in our society which could actually be helping or even mitigating the condition. Otherwise, we need to explain almost 4 to 5%, a third of the difference in even in the World Mental Health Survey, which use the same statistic, same methodology to measure the mental health disorder. The differences between the developed countries and our country, being smaller in our country, need to perhaps be explained. It another explanation which we seek is a better outcome for mental disorder in our country, which has been time and again talked about. Why is it so? If treatment available over, there are fewer psychiatrists. Reported way back in 80s, the international pilot study of schizophrenia, and more recently in 2000, a multi-center study which showed better outcome of psychotic disorders. So it seems that while the prevalence is something that we have to worry and we have to plan, we also have to look at some strengths which could be making prevalence lower than the international figures in the developed countries, where all these things were available even in a better form, numbers of psychiatrists being lower treatment gap, treatment available at many other places, and perhaps lesser stigma as well, but yet having higher lower prevalence here, we need to perhaps explain. So with this, I perhaps stop here. The way forward has been that what we found as a difference, urban-rural difference, has now been planned at the national level to look at urban prevalence conditions in mental illness. Studies that have been launched and has been going on. Maybe in a couple of years we will have that data as well. Be able, as you know, that urban population is increasing day by day. Close to half the population in our country could as well have become urban today. So, National Mental Health Survey leading to current urban mental health survey that is going on, and the figures that we have got in terms of 10% of the population, suicidality being quite serious, that we need to consider, and also of course the cost for treatment has also been estimated in the National Mental Health Survey, is something that will educate us in terms of planning. The last point, thanks to Dr. Vig and Dr. Srinivasa Murthy, who launched a public mental health activity in our country, who are responsible in ensuring district mental health survey being initiated, and also making deep professionalization and also taking the health to a community level through a public health system that has actually made perhaps the treatment availability and the prevalence rates can get better, and mental health in our country perhaps is getting better. The last part is the digital technology, which has been recognized, and very recently in the COVID period, which we used it for taking mental health through another layer of lay health counselors to social workers to be able to be available as a first triage of help for psychosocial help. And this led to the current in the finances ministry announced a huge budget to be able to take mental health in a digital field, the digital mental health action plan, which has been rolled out, and of course several centers in the country have already been participating in making it a success, and hoping that mental health will be reached to all as envisaged by the mental health report of this second report. We will be hopefully able to achieve that in a short while. Thank you very much.
Thank you, Professor Gangadhar, for giving a snapshot of the National Mental Health Survey, which is very different from the many epidemiological studies which have been done in the country. Over last 50 years or even more than 50 years, India had a rich tradition of epidemiology of mental health disorders in the community, rural as well as urban. But this survey stands out from all those previous studies in the fact that fortunately Professor Gangadhar had access to better technologies, better manpower, trained workers, that this survey did not limit itself to head counting, but it also studied that what kind of services were available in the community, both urban and rural. he used the word, the phrase mental health gap up to the 75%. I may just tell you that what mental health gap 75% means. It means that 75% of people who are in need of mental health care either are not receiving any care at all or receiving it very inadequately. So that is mental health gap which we are treatment gap, which is we are having in this country. And for this, till few years ago it was 83, 85. Fortunately some improvement has taken place, but I am sure that we still have a long way, and in our lifetime we should be able to see that. Thank you very much, Professor Gangadhar. Now we come to the another survey, which is again a landmark survey. The principal investigator of is Atul Ambekar. Atul Ambekar is my colleague from AIIMS, New Delhi, from where I superannuated as the professor and chief. And currently I am at the Holy Family Hospital as a senior consultant psychiatrist. And thanks to the Holy Family Hospital that I see a large contingent of audiences here, especially from the College of Nursing. Thank you very much. So, Professor Ambekar is the principal investigator of National Drug Use Survey, and he is also advisor on drug dependence to World Health Organization Geneva. So may I request you, Atul, to kindly give us a snapshot of this survey which you have done. Kindly have two mics because I think there is some audio issues. Yes.
Good evening and namaskar to my fellow panelists as well as ladies and gentlemen joining us in person as well as online. Thank you very much for this opportunity. So, in his opening remarks, Professor Khandelwal alluded to the fact that mental health receives much less attention than it deserves. I would say that within the area of mental health, the area of substance use or addiction receive much less attention than they deserve. It doesn't mean that the issues related to drug use or addiction do not dominate our discourse. In fact, in our discussion, including in the public discussion, in media also, you see these issues figuring very prominently, but not in an empathetic manner. So people affected by addictions, they do not get that kind of empathy which they deserve, either collectively or individually. So I am going to talk about, I will request my slides to be uploaded please. So I am going to talk about very briefly about the report of this survey which we conducted for the Ministry of Social Justice and Empowerment. It's really surprising that despite making so much noise about substance use or addictions in India, till 2018, Government of India did not have reliable or credible estimates of how many people are actually affected by addictions in different states of the country. So there was some idea about the national level, but this was the first time that such a large, elaborate exercise was carried out at the national level, but which also provided us data at the level of individual states and union territories. Have you been able to locate my slides, please? Yeah. So, as I was saying, this was a very large, elaborate exercise. Throughout the country, more than 2 lakh households were visited, more than 5 lakh individuals were interviewed. And when I say individuals, I mean people ranging from 10 years to 75 years. So males, females, children, adults, elderly population in rural areas, in urban areas, representative population of each individual state and union territory. That kind of information was collected. And some advanced methodologies were collected to get information about illegal drugs, because that's where people are reluctant to report about. So next slide please. Right, so as we know, there are what we call as psychoactive substances or addictive drugs. A wide variety of them are available. We in India have not been shy of using these substances. So our society has been using these substances in various forms for literally thousands of years. But of late, there has been a change in the pattern of their use, a change in their prevalence, and the change in the burden which the society experiences because of their use. As I was saying, 2019 was the first time when such survey report was available. Next please. So this is the report I'm going to present. I had the fortune to just lead this report, but this was really a culmination of work of a wide variety of literally hundreds of people who worked together in this, from All India Institute of Medical Sciences as well as 10 other medical institutions across the country, including NIMHANS Bangalore. Next, please. So I'll straightway go to the data, and as we can see here, about 14.6% of Indians, that means 10 to 75-year-old Indians, about 16 crore such individuals can be categorized as users of alcohol. But of course, as far as mental health problems goes, we are more interested in people affected by alcohol use disorders. What we see at the middle figure, problem users. So about 5.7 crore Indians are affected by problematic use of alcohol, or they can be said to be suffering from alcohol use disorders. Next, please. It's predominantly a male phenomena, something which we know in the society around us as well. What the national figures often hide is the fact, the kind of diversity which we have in India in terms of prevalence of alcohol use. Next, please. So as we can see, there is a wide difference in terms of what percentage of people consume alcohol across different states. There are some states it's very high prevalence, some states it's very low. Next, please. Of course, for us, more important are the figures not of use but suffering from addiction, alcohol use disorders. And these are the states where more than 10% of the general population of 10 to 75-year-old is affected by alcohol use disorders. So if this is not a public mental health crisis, I don't know what is. So I wish, next please. So these are the states, Tripura, Andhra, Punjab, Chhattisgarh, Arunachal, where more than 10% of their general population is affected by alcohol use disorders. Really worrying statistics there. Next, please. As I was saying, at the national level, we have about 5.7 crore individuals, and in many states, these figures run into lakhs in terms of number of people who require help for alcohol use problems. Just look at the figures for UP. 1 crore 60 lakh people, they require help for alcohol use problems. Next, please. The next category of drug which we were interested in was cannabis, which is available in India in the form of both bhang and ganja or charas. Interestingly, bhang is not illegal in India, but ganja and charas are. Overall, at the national level, we have about just more than 3 crore individuals using it, and about 72 lakh people affected by cannabis use disorders. More so, this is more so in case of ganja. About 50 lakh people have problems because of their illegal cannabis use, charas ganja use. Next, please. But the major problem drug category for India happens to be this, opioids, which means either opium or heroin or pharmaceutical opioids. As we can see here, as many as 2.3 crore individuals use it, but a far higher proportionately number of people, which means 77 lakh people, they are affected by opioid use disorders. And what's most worrying is, among all these opioids, the most addictive opioid, that's heroin, which the UNODC has also recognized as the most damaging or devastating drug across the world, that has the highest prevalence of use in India among all illegal drugs. We can see about more than 60 lakh people are affected by opioid use disorders on account of their use of heroin. Next, please. And this also, we have large amount of, next please, large amount of variations across the country. If we look at the names of the states here, the top positions in terms of opioid addiction are occupied by those states which are located in the traditional heroin smuggling routes. If you look at the top 5 states here, they are in the northeast, followed by next 4 or 5 states, they are towards the northwest, towards the Pakistan border. And these are known heroin trafficking and smuggling routes. So it's very clear that our drug problem is mainly on account of heroin, and that heroin which is being smuggled outside in our country. Next, please. Next, please. In terms of, again, these are the states where number of people in lakhs who need help for their opioid use problems. And you can see even Delhi figures in this list. So Delhi is also a state which has substantial number of people with opioid use disorders, despite being a small state really. Next, please. For other drugs, these prevalences are not very high. So in terms of problems, next, please. Our major drugs happens to be alcohol, cannabis and opioids, and the number of people who require help really run into crores. Next, please. If we compare from the world, our statistics really tell us that for all other drug categories, much lesser number of Indians use them except for opioids, which is the most damaging, most harmful, most devastating drug category, and unfortunately, for that we have very high prevalence in India. Next, please. For us, the more worrying statistics were these: the mental health care gap or the treatment gap, which was reflected in the addiction treatment as well. Just look at those figures for alcohol. Just about 1 in 180 people with alcohol dependence report that they have been able to secure admission to a hospital for alcoholism treatment. So the care is really wide there. Next, please. As far as treatment facilities goes, in our country there are different kinds of treatment facilities available in the government sector, in the private, in the NGO sector. Unfortunately, these are too few and far in between, and they also are marred by the quality and regulation issues. Next, please. So this scale up is ongoing in the form of some programs which are being launched by the Government of India after the publication of this report. Process is still slow. The kind of attention, particularly the state governments, are expected to pay to in terms of provision of addiction treatment services, that still is not visible, unfortunately. We have medicines available, but these medicines are also very tightly regulated, and hence they are not very easily accessible to people. Next, please. So inadequate attention to treatment of addiction by state governments is a major challenge. Another important challenge is the NDPS Act itself, which criminalizes a symptom of a mental illness, really, substance use itself. So that's something which needs urgently to be reformed, and the stigma, myths, misconception in the society, those need to be addressed. Next, please. So I'll conclude with the statement by Kofi Annan, former UN Secretary General. Drugs have destroyed many lives, but wrong government policies have destroyed many more. Thank you very much, ladies and gentlemen.
Thank you, Atul. Thank you very much for taking us through the problem of drug use in India. I am sure that it must have removed many of the misconceptions which many of us carry, about the drug use. And unfortunately, the two major drugs, alcohol and tobacco, did not figure here.
Tobacco did not.
But they are legally, socially sanctioned drugs. So alcohol is a legally, socially sanctioned drug which is available all over, everywhere, and it has become a kind of problematic situation. But I am sure that this report, which is a landmark report in the sense that it covered a huge number, all the districts of the country, a very large number of population from 10 years of age to 75 years of age, and also covering the spatial population, for example, prison population, LGBT community, street dwellers. So it's a very wide coverage which this report has, and I am sure that the health administrators and planners will take this report very seriously and come out with some very cogent treatment guidelines, and devote more infrastructure, manpower and resources. After covering that what has been happened in India over last many decades and where we have made progress, may I now now we come to the current World Mental Health Report 2022, which was released only 2 months back, and where we will have presentations on this report by Dr. Koushik Sinha and also by Dr. Andrea Bruni. Koushik again has been a dear friend and colleague from AIIMS, and where he is additional professor of psychiatry and is expert on digital psychiatry and mobile health and electronic health, eHealth, right? So mHealth, eHealth, and the beautiful posters which I think all of you have received They have been designed and created by Koushik only. Thank you very much, Koushik, for this. Those posters have been appreciated. So, may I now request you to kindly make your presentation?
Yes.
Don't worry about the time.
Yes.
So, have we sorted out the audio issue?
Yeah.
Okay, great.
So, I'll be audible here, no? Okay.
You can use it.
Yeah, I think I'll be. Thank you, sir, and thank you all my co-panelists. I'm the only one without some huge achievement behind their names. So my co-panelists, everybody has been a part of either the previous mental health report or the national surveys or the current planning and programming. But sir has been my teacher, and most of the people who are on the panel has been my teacher at some point or other. So I'm still trying to find the job that was given.
Koushik, you are young and you still have a long way to go.
Thank you, sir. Hopefully, sir.
All the awards, laurels, achievements will come through your way. Don't worry.
Anyway, so my task was to, understand the World Mental Health Report 2022 and to guide all. And my next speaker, Dr. Bruni, I saw his presentations, like he would be providing also insights onto that. So it has been a huge work, this World Mental Health Report of 2022 that has come. And on the outset, it has been, it is a wonderful read also, because it's written very lucidly, and it's written from a perspective that makes us reconsider our current priorities about mental health. So in that way, it's an eye-opener. So as Professor R.S. Murthy said, that in 2001, the first World Health Report came out. That was not the mental health report. It was a health report which was focused only on mental health, and there were 10 recommendations. And after that, a lot of things have happened, which Professor Khandelwal also briefly alluded to. So most significant about which was, one of the thing was the UN Convention on the Rights of Persons with Disability, or UNCRPD, subsequent to which we have our Mental Health Care Act, which is now based more on a rights approach of those who are suffering from mental disorders and other disabilities, compared to a benefactory or beneficial approach as it was before. In 2015 to 2030, UN also came out with Sustainable Development Goals. These are goals which each country is supposed to adhere to by 2030. And majority, if not all of these Sustainable Development Goals have a component of mental health attached to them. So many of the Sustainable Development Goals will not be achievable without having a mental health policy or mental health program for the country. Very recently, in 2019, the UN General Assembly, the body said that universal health coverage should also include universal mental health. So previously, it was for some other things, and mental health was as if somebody sitting in the corner, and now it is a part of the universal health coverage. But nevertheless, despite all these improvements, it became pretty clear that in many low and middle economic countries, mental health policies are there, mental health programs are there, but on-ground implementation seems as if it's business as usual. So one of the wake-up call, and that's the name of this, Transforming Mental Health for All, this book or this monograph, is that business as usual for mental health will not do. We'll have to re-strategize and transform whatever is there. Otherwise, another 20 years might go on and we'd see some progress, but not at a level that we want our countries and the world to go on. So, Dr. Murthy also talked about this, that there is this distinction between mental health condition, mental disorder, and psychological disability. Mental health being, it's something well-being, and it's not just the absence of disease, whereas health condition are sadness, anxiety, or worries, apprehension, those kind of things, whereas mental disorders are the severe end of the spectrum, where there is significant distress and dysfunction, and that dysfunction results to psychological disability. So what in the very first chapter, or on the chapter of the book, it's there, Principles and Drivers of Public Health, it says that one of a good tool for advocacy is that with good mental health, not only mental disorders, the society as a whole and the person thrives. So if one has a better mental health, there are more chances of positive relationships, there is more contribution to the community, which results in more function and therefore a gain in education, earnings, better living choices, better new skills. and which results in the whole population realizing about their own abilities and being able to cope with various stresses. On the contrary, mental ill health is associated with poverty, and they are synergistic in that one leads to another and it goes back and forth. So if there is illness, if there is poverty, there might be poor educational attainment, school failure, domestic violence. So you can go through the whole circle, and there will be poor mental health condition, which will result in more drug and alcohol use, which Professor Dr. Atul Ambekar was talking about, risk-taking behaviors and including self-harm, and it goes on. And therefore, it becomes very obvious to us that mental health is not something that's only biological. A long time back it has been said it's a biopsychosocial, and therefore it seems to be reiterated that there are individual factors which are biological, there can be family and community factors which are, and there can be structural factors. And therefore it's a responsibility, I guess, of all these components of the individual, family, community and the country to enhance the protective factors of mental health and decrease the risk factors. On top of that, there has been this recent onslaught of various global threats, which has made our situation and our mental health condition even more precarious. Primarily, the economic inequality. Over the last decade, the gap between the poorest and the richest have been increasing by more than tenfold. There has been public health emergency, not only the COVID pandemic, but the Ebola in West Africa, Zika virus. We know there is always one pandemic or another, or at least one health emergencies which are going on at all points of time around the globe. Followed by that, there has been an unprecedented humanitarian emergency and forced displacement in the last decade, with in 2021, 84 million people worldwide were forcibly displaced. In 2022, 247 million people are estimated that they need some form of assistance. And finally, there is the climate crisis, which is so huge. It infiltrates all parts of life, including food security, as well as climate-related or climate-associated anxiety and climate-associated nihilism, which is now being seen in young adults. So what the report says that with all this onslaught today, more than ever, it is now more important for us to understand what can be done, the strategies that we can take to improve the mental health. So the mental health report starts with very simple facts. Where do we stand today? This is same as Gangadhar sir was saying. Globally, somewhere it's around 13%. The Americas or Europes are apparently more, but there is some confusion whether it is because of a proper reporting, and there are under-reporting in other areas. If you look year by year, this value of around 13 to 15% of mental health disorders have remained quite stable, which essentially means we are not being able to decrease this value despite the efforts that has been put in the last 20 years. So this is a curve from WHO from 2000 to 2018. Finally, what we see is that of this 970 million, that's the 13% of the world who are, affected. What we see is that a majority of the people are suffering from anxiety disorders and depressive disorders, which essentially means that if a government focuses at least on the top four, which are anxiety, depression, the common mental disorders, as WHO says, developmental disorders and ADHD, the return would be highest. This does not include the substance use disorder, which is almost at another 20%, 21%. So that's a separate, this chart doesn't include. So even in the mental health gap, that's a WHO program that talks about the gaps which are there, alcohol and substance use falls under the top 5 conditions which are there. So at the end of the day, currently we are at a situation where 1 in 8 persons live with mental health conditions, but the treatment gap, which sir was saying, is around 71% globally. And the problem is in most of the country, the health budget is less than 2% or around 1% in our case. The only thing which has happened through a concerted effort all throughout the world is that we have seen, and that's the good news, is that we have seen a decrease in suicides over the last two decades. And this decrease, even more surprising or more heartening, is that they are more in the middle and low income countries. And there have been a lot of programs, like for example, this monograph gives example of Sri Lanka where pesticides have been banned. In India, there are in various parts of the country, pesticides are now locked up in a central reserve in a village, and all the farmers go there and collect. So simple things, lock and leave programs, they help. That was about death. even for disability, as Sir was saying, Professor Khandelwal was saying, that depressive disorders and anxiety disorders are now one of the top, or at least two of the top 10 causes that causes disability in the years lived. So not only death, but also in disability, mental health disorders have now become a significant point. So essentially, I'll quickly skip this because I think Dr. Bruni would be talking also about this. Next, please. Yeah. The final part about where we are today, in which this monograph does a very good job, is that it says what proportion of the research goes into mental health. And we know that without research, progress, at least in what we need for our country, will never be there. What we see is that in low income and low middle income countries, we have only around 4% of investment in research. And even in high income countries, where there is almost 8% of the research funding goes to mental health, we see the majority of the research is either in etiology, underpinning, or the biological part. The needs of the community or public services and how their quality can be improved. The research money that is going there is scarce. So it's 2% or it's 7% of the 4% that we are spending goes into what the community needs. Although primary research and baseline research are very important, but that also shows that these are the areas in which we do not actually know what would work. And as for the government's commitment, majority of the country now, since the last 2 decades, where a strategy has been made for mental health, most of the countries now have a policy or plan. India did not have, now India has a policy, and India had a plan before, but now there is also a policy. There is also an alcohol use policy. A lot of things have happened. But the countries that report that they are fully compliant with the policy or plan, it decreases, falls to 45%. And countries that report that implementing a fully compliant policy or plan is less than 5%, that's around 3%, which simply shows that a lot of things are on paper, but their implementation is where we need to focus. And to focus, we need manpower, which my predecessors were talking about. What we see, so this is another chart about the various mental health resource person we are there. And again, in low income countries, per 1,000 or per 100,000 population, we have 0.1 psychiatrist, 0.4 mental health nurses, and so on. Whereas the number is around 8 to 10 of psychiatrists and around 29 to 30 for mental health nursing in case of high income or other countries. Globally, it has been shown that because the resource of psychiatrist doctors, they might be too difficult to produce in a short term because of the cost involved. Other mental health specialist cadres are required. So globally 47% are mental health nurses, and then another around 40% would be of social workers and other specialized workers. Sadly, it is this second part which is lacking in the Indian system, which is more of a top-down system, where we have more psychiatrists, clinical psychologists, but the other supporting cadre, that number is decreasing. And there is a need to increase that. So after that, it goes into the book, then the monograph then goes into advocacy, where it says that at the end of the day, we need to improve mental health, not only for improving the mental health, but also to prevent human rights violation. And the book tries to give you small stories about lived experience of people, what they have gone through. It's not only a data. So it gives experience of a lot of people. One of them I have put up is that pinned down by the policemen and paramedics, gagged and handcuffed like a criminal, as I was knocked and unconscious by a medical cocktail. So it talks about the lives that many people live, and where surreptitiously or even without wanting it, the necessary evil where human rights violation happen. But things have been showing improvement, and it is possible. Next, please. Yeah. So there are two heartening things, or two heartening chapters that talk about the good things which have happened all over the world. For example, the anti-stigma campaign. So there has been in England, in Australia, in Canada. I have just picked a few of them. So these anti-stigma campaigns have been remarkably successful, and they can be reproduced around the world. And for return of investment, for example, it has been done in Peru and many other countries, even in Pakistan. The statistics is showing that the cost-benefit ratio, that is the return on investment for depression and anxiety, can be 5 times to, it's around 4 to 5 times. So for every dollar or every 100 rupees you put in to that, the return on investment is about like 5 times would be like $5 or 500 rupees or something like that. So these are examples, some of the examples which are there. So in Jamaica, investment of 115 million to scale up treatment and depression and anxiety was done. And it was estimated that around 434 million was added back to the economy. To do this, there has to be some foundations of change. It starts with the global foundations. I will not go into detail like my predecessors have talked. So there has to be some human rights foundation which the UN has given. Then there has been World Mental Health Survey, Image Gap Intervention Guide, ICD-11, all those. And the political will advocacy needs to be done, because political will consist of at least 3 things. There has to be an expressed political commitment in which the country says, yes, I am working for mental health. There has to be an institutional commitment and a budgetary commitment. Incidentally, and I think currently, all these 3 commitments have been met with the National Telemental Health Program, which Professor Gangadhar sir was talking about, and I think Professor Murthy would be talking subsequently. So it has been shown that with simple investment and increase in the community mental health centers and improvement in resources, it is possible for countries to become self-sufficient and those community services to become self-sufficient to generate further resources themselves. Although it says that no country will ever be able to meet the mental health needs of their population without mobilizing additional funds and human resources, there have been innovative strategies for financing the sustainable development in mental health. For example, we always think that mental health funding should always come from the mental health or the health budget of the country, but in Peru they have taken it from other development budget and they have made mental health as a part of all those. So mother-child program, educational program, from all those places a budget has come which has helped in the long run. Additionally, there is need, so it reiterates the same thing, that mental health is not only for psychiatrists, not only for specialists, but there has to be a tired care approach, so the resources are utilized to their fullest. And to promote, some priority areas have been decided, which is the suicide prevention, child and adolescent mental health, and workplace mental health. And the suicide prevention, we know, like limit access to means, for child and adolescent mental health and for mental health workplace, certain strategies have been done. I am quickly going forward because in a sense these are nitty-gritties, but what this guide or what this monograph guides us is a very easy to do or at least easy to understand advocacy and restructuring which can result in revitalization of some of the services. So for the restructuring, there are evidence now that community-based care works, but everything cannot be put on the community. So general hospital plus community team seems to be a good idea. There has been a movement to move people out from asylums or mental hospitals, but to move them, there is a need for having supported living services. Otherwise, they're again left on the streets. So key social services, including child protection, access to education, employment, social benefits, they are all essential to have a mental health program in the country that is moving forward and that is reaching the masses and their target masses. So essentially it envisages a huge complicated diagram which talks about mental health in general health care, psychosocial education, day care, vocational assistance, and it says that whatever way these targets can be reached, it's good. So essentially what we see is that in many places such kind of benefits which are not directly targeted as mental disorders have result in spillover effect or halo effect into improving the mental health condition of various people. So in conclusion, what this monograph tries to tell us, motivate us, enthuse us and goad us to action is that there has to be some commitment, and the commitment has to be at every level, and that commitment can be achieved by reshaping our environment and by strengthening the mental health care whichever is there. At the end, in the back page, it writes that mental health is critically important to everyone, but drawing from the latest evidence which is available, there are examples all over the world in which, despite limited resources, structural change can be possible. So essentially it gives a message of hope. That is what this monograph is about. I'll hand it over back to sir now so that further discussions. Thank you, sir.
Thank you, Koushik, for excellent taken us through all the chapters, the background, the possibilities, and what has been achieved, what is yet to achieve. I think you have done a remarkable job. Thank you very much, as expected. So now we come to the next presenter, which is Dr. Andrea Bruni. Dr. Andrea Bruni is the mental health advisor to the Southeast Asia Regional Office of World Health Organization, New Delhi. Dr. Bruni, first of all, my welcome on behalf of all of us here to India. And you have recently come to New Delhi, and you have joined this regional office at a very exciting time, especially I can say about India, when India is making huge investment in health, in education, in cleanliness, and you might have now read about Ayushman Bharat and number of other insurance coverages for its population. So it's a very exciting population, a very exciting time, and I'm sure that you will be asked to give your inputs to all these schemes and plans and policies during your stay here. And I also hope that you find India a very hospitable, warm and friendly country. And people who know about SERO region, Southeast Asia Regional Office of WHO is located in New Delhi. It has all the countries of this region except Pakistan. Pakistan has chosen to go to the AMRO division. So Dr. Bruni is responsible for mental health policies, advice, etc. for a large number of population. And just a brief introduction of Dr. Bruni, that he is a medical doctor specialized in psychiatry. He holds the international master degree on mental health policy and services and mental health, human rights and legislation diploma from Pune, India. The previous master's degree is from Portugal. He has 15 years of experience in various countries of the world, Latin America, Africa, Middle East, etc. And he is highly committed to promoting the rights of persons with disability. So, Dr. Bruni, may I ask you to make your presentation? Thank you very much.
Thank you very much. I hope I'm audible. Can you hear me?
Yes, we can.
Yes, thank you very much for the warm welcome. I'm very excited to be here in India, and I'm also very excited to be with you today, presenting on the World Mental Health Report. I'm going to share my presentation. Please let me know if that is visible.
Yes.
Great. So there will be some duplications. So I will try to skip some parts to avoid repetitions from the previous presentation. So let me just emphasize at the beginning of this presentation on this one key word, which is transforming, because this report is about transforming mental health for all. And one of the objectives of my presentation today will be to highlight how we are supposed to transform mental health for all. This report, as was mentioned, was produced in 2022 by the Department of Mental Health and Substance Abuse of the World Mental Health Organization. It is structured on 8 chapters. The first one is an introduction, and the second one is on principles and drivers in mental health. And here I extracted some of them. It was already mentioned that mental health is critically important for everyone, everywhere. Mental health is a right, and everyone has a right to mental health. And mental health is relevant to many sectors and stakeholders within and beyond the health sector. And is important, as was mentioned earlier, to connect, function, cope, and thrive. This was already said, so I will just move forward. COVID-19, mental health has been widely affected by the pandemics. We are all aware of it. And this is also because of new stressors, which include potential health impact of COVID, but also public health and social measures that were implemented to limit the spread of COVID-19. Certain conditions, certain common mental conditions, such as anxiety and depression, have gone up. Depression by 28%, anxiety by 26%. And at the same time, there was a very important disruption in mental health services. 44% of countries reported disruptions to mental health care in 2022. And disruption normally was more pronounced in community-based mental health services. So at a time where societies needed mental services the most, they were essentially being disrupted. And I think this is an important lesson learned for all of us. Something was already mentioned about epidemiology, so let me just go quickly through this. 1 in 8 people live with a mental disorder. In the CR region, it is estimated that it is 1 in 7. 1 in 100 deaths are suicide. And in our region, it is estimated that every year more than 200,000 people die because of suicide. And people with severe mental conditions tend to die 10 to 20 years earlier than the general population. I think this is a very alarming data, and this higher mortality is mainly explained in terms of stigma and discrimination, because people with severe mental conditions suffer, like many others, of non-communicable disease that can be prevented, that can be treated, but because of a barrier to access to general health services, and not necessarily mental health services, people have people with severe mental disorders have higher mortality. This is also partly attributed to irrational prescription of psychotropic medications. It was mentioned earlier about the treatment gap, which in this slide is referred to as services gap. So the gap existing between the needs of populations in terms of mental health and what is actually offered by government. And in many cases, unfortunately, this gap is very huge all over the world, including in our region. There are also other key gaps. One is the information gap, because there is a lack of data and research on mental health. There is governance gap. Few countries implement plans that comply with human rights. And there is obviously a resources gap. It was mentioned already that on average, 2% of countries' health budgets goes to mental health, despite the huge burden represented by mental disorders. And unfortunately, out of this very small proportion of the health budget, which is oriented to mental health, normally an important proportion of it is still spent on psychiatric hospital. And very little is left to community-based mental health initiatives and mental health networks. Good mental health is fundamental to any individual health and well-being, and investing in mental health for all advances public health. It can reduce suffering and improve health and quality of life of people with mental health conditions. It was already mentioned about this one study of investing $1 per capita, reducing by 5,000 years lived with disability per 1 million persons. So I will not take more time on this. I rather emphasize that investing in mental health is also important for physical health, because comorbidity is in fact the rule rather than the exception. There is a very high comorbidity between mental conditions and physical condition, and this is an additional reason for integrating mental health into general health care, including integrating mental health into PHC. The investing in mental health is also needed to stop human rights violations, including those violations occurring in health and in mental health services. We are unfortunately very much aware that even in mental health facilities and institutions and hospitals, there are common and sometimes very severe and extreme violations of human rights. In this sense, the WHO has developed an initiative which is known as Quality Rights, which is growing and which is widely available in internet to anyone. The CRPD is basically the Convention on the Rights of People with Disability, is the most important document of reference for all of us in disability and mental health. It was mentioned already about the importance of commitment and the three types of commitment. And basically, historically, retrospectively, expressed commitment and institutional commitment are rising, but budgetary commitment still needs to increase. So more commitment in terms of budget and resources, including financial resources dedicated to mental health, is expected from countries. Here you see the example from Sri Lanka and the post-tsunami, which essentially catalyzed a lot of interest to mental health and psychosocial support. And this, in a way, helped reforming mental health services and basically allowed the establishment of community-based mental health services in the country, which were basically nearly non-existent before tsunami. This is the usual concept of building back better and to look at emergencies or humanitarian situations in terms of opportunities. Moving from morbidity to mortality, we have mentioned that in our region, more than 200,000 people die because of suicide every year. What can be done? According to the WHO Live Life approach, there are 4 key strategies to be implemented. Limit access to means of suicide, interact with media for responsible reporting, foster social and emotional learning, and early intervention. So here to the right, you have some information from Sri Lanka, because Sri Lanka worked for many years on the ban of pesticides. Pesticides are commonly used as a means of suicide, especially in rural areas, and working on pesticides and on banning pesticides in Sri Lanka determined a drop of a suicide rate of 70% in by 2016. I can focus now in limited time on all these approaches, but working with media is also very important, and there are WHO guidelines, again, available on internet on how to work with media. Capacity building often is provided to journalists and media workers on how to report on suicide, and there are very clear do's and don'ts about reporting on suicide. Also early intervention, and again, as it was mentioned earlier, MHGAP, which is the main program for integration of mental health into primary healthcare, has an entire module dedicated to self-harm and suicide prevention. So a mix of services and supports is needed. People with mental disorders have very diverse needs, so there's not one kind or one single answer is enough to address those needs. So we have services from the mental health services in general healthcare, for example, PHC, or for example, the general hospitals with a mental health unit, community mental health services, and even going beyond the health sector. We will see an example very soon. Some speaker earlier mentioned about the process of deinstitutionalization. This is something very important to move away from psychiatric hospital. There's a number of reasons. We don't have enough time now to list all of them. But first of all is because of human rights. Secondly is because of public health. And thirdly is there's a financial reason to that, because very often psychiatric institutions absorb a lot of resources that that are finally and ultimately dedicated to a very small proportion of people that can benefit of those services, while investing in the community can benefit much more people. The institutionalization, of course, is not something that can happen overnight, and is not something that happens like in a silos or in an aquarium. The institutionalization is something which is a cross-cutting, which implies, as was rightly mentioned earlier, establishing alternative services in the community, several types of services, including residential facilities, but also it has to do with finance and budgeting. And here we have some examples from mental health beyond the health sector. Again, this is a very dense slide. I will focus maybe on this example from Peru, which is one of the examples most familiar to me because I've been working in Peru for 5 years before moving to the Middle East and before coming here to SERO. And housing was a very important initiative. It started very small, as a very small initiative in Peru, to set up only 8 sheltered or halfway houses, as they call them in Peru. Only 8 houses with the capacity of 8 people each. And this allowed an initial, to take the initial step towards deinstitutionalizing a very small psychiatric hospital in a very remote area of the country in the forest of Amazonia. There was this small psychiatric hospital with roughly a capacity of 50 beds. And this was entirely shut down. And this was an initial step that demonstrated that it was possible to work with people that had been living there for so many years in very terrible conditions. I remember this one person that lived for so many years in the psychiatric hospital, and when finally came out of the hospital, finally started talking again. Everyone thought that this person was not even able to speak. And finally, when left the hospital, started speaking again and moved to one of these sheltered houses that were established. After this initial, I would say, pilot phase, Peru worked very hard on setting up many more houses, including in the capital city, Lima. This process, of course, again, is not done in isolation, is done along with many other transformations, including setting up community-based centers. In the case of Peru, these centers were centers with no beds, but with essentially 3 functions. One was to support, to provide treatment and care to people that needed it. The second was to promote mental health within the community and to work with all relevant stakeholders in the community. And thirdly, it was to activate the non-specialized primary healthcare level through training, capacity building, supportive supervision, and also establishing a system of referrals and back referrals. So this is all about community-based mental health networks. These are the path to transformations. This has already been mentioned earlier, so I think I can just skip it. And one final message about strengthening mental health care and improving access to mental health care is to build community-based networks. Again, these networks are diverse networks with multidisciplinary teams. There's not one single facility that can address issues related to mental health. We need a diversified kind of networks. Move away from custodial care of psychiatric hospitals towards the community, diversify and scale up care options for common conditions. And mHealth can be very instrumental in this sense. Make mental health affordable and accessible for all. deliver person-centered human rights-based care, engage and empower people with lived experience. This is the end of my presentation. Thank you very much for your attention.
Thank you very much, Dr. Bruni, for a exhaustive presentation about the World Mental Health Report 2022 and the vision it holds for our region. Thank you very much once again. May we request the last presentation of this evening by Professor Pratima Murthy. Professor Pratima Murthy is the Professor of Psychiatry at NIMHANS, Bengaluru, and its current director. And she is involved intensely with the Ministry of Health and Family Welfare about the vision of mental health in India. So, Professor Murthy, may I now request for your presentation. Thank you very much.
Just a minute, I'll just get my presentation on the screen. Yeah. Okay, so thank you very much, and it was a pleasure to listen to everybody and really get a glimpse of the World Mental Health Report and the context in which it occurred. What I'm going to try and talk to you about in the next few minutes is really what has happened in India. And I thought, the theme in terms of the World Mental Health Report, in terms of how it refers to India, is possibly three areas. One is to inform, reform, and to transform. The next slide, please. So, we need a lot of information about mental health. We heard about the National Mental Health Survey and the fact that 1 in 10 people needs, has a psychiatric diagnosis. Now, for every one person who has a psychiatric diagnosis, there are probably 7 or 8 people who have various kinds of mental distress related to a situation where they need help. Unfortunately, even the people with diagnosed mental disorder, there is a huge treatment gap that you heard of, which is 75 to 90%. So these are not gaps, but chasms in terms of access to mental health care. And the third, most important thing, which many speakers have alluded to, are the attitudes towards mental illness. We know that there is a lot of stigma around acknowledging a mental illness, getting help for a mental illness, and this makes it very challenging, even when you provide services, to make sure that people connect with services all over the country. And this is not just a rural issue, it is an urban issue. It is not just an education issue, it also occurs among both people with education and illiteracy. So the stigma is something that pervades the whole context, and therefore we must talk more openly about mental health. And so we've had enough, we're at least beginning to get information, but I think we need to develop mental health literacy to really understand and identify when we need to reach out, how we can improve our mental health, and so on. The next slide, please. So after the information, we needed reformation. Dr. Bruni referred to the conditions in mental hospitals, and certainly in the 1990s, it was the National Human Rights Commission that started looking at the various mental hospitals in the country and found that there were a lot of issues. Patients were predominantly involuntary patients. Patients were sometimes, it was worse than jails in some places. They were mostly custodial in nature. They were fed very poorly. There was very little that they would do in the hospital, and they tended to stay for long years in the hospital and sometimes died in the hospital. Therefore, there was a need to reform these institutions from custodial institutions to therapeutic institutions. And the Mental Health and Human Rights Report, which was carried out in 2008, showed that change was possible. Now, even though the report of 1999 came out, there wasn't much change. So sometimes you need drivers of change. And sadly enough, the driver of change was the Erwadi incident that many of you might know about, where there was a fire in one of the dargahs in Tamil Nadu and several people perished. And that's when the Supreme Court took notice of the fact of the care in mental hospitals. And many from the NHRC, they were actually rapporteurs who went and visited these hospitals and made sure they were transformed. And indeed, when we went back to the hospitals 10 years later, many of them had transformed, reduced themselves in size, made admissions more voluntary, had a lot more occupational and rehabilitation efforts, were engaging with NGOs and discharges back to the community. However, when we went and did a survey of women, from the National Commission for Women, we actually found that even though there were kind of reports of poor care and so on, sadly, many of the women felt happier within the hospitals than at home. And many families tended to abandon these women because of stigma, because of poverty, because there was worry about how they would manage somebody with mental illness in a very small household. So there are lots of social reasons why we need to actually develop support systems for people in the community. So where these hospitals were monitored, there were a lot of changes as compared to hospitals who were not monitored. The fact that there is transformation potential in these institutions, and perhaps getting these institutions as part of a larger network of services which focus on developing community services closer to where people are, is very important. But I think we also must remember the reality of the country, that we have very, very poorly developed community-based services. We have very few services for people with severe mental illness outside of these institutions. So I think we need to take, and we need to avoid institutionalization. In a survey in prisons, we found that there is a large amount of mental health morbidity as well as substance use. And therefore, unless we develop good community care services, we will get into this problem where people move from mental hospitals to prison, something that has been seen in other countries and we must be aware of. The next slide, please. So the journey, we've already talked about the policy, the mental health policy in 2014. We have a very progressive Mental Health Care Act, which is a rights-based act. We also have the Disabilities Act, which looks at persons with disability and includes mental illness as part of that disability. These are all very progressive acts, and they've helped us to kind of mold mental health into a rights-based approach. And they put the responsibility of states to develop care and services for persons with mental illness. We also had a report of a technical committee on mental health of the National Human Rights Commission, where again, the focus was on trying to see what were the resources. Dr. Gangadhar talked about the mental health survey. That, as well as this, talked about the resource mapping, the need for resource mapping to find out where people need to go. If I have a problem, a temporary problem, whom do I approach? How do I get help? If I need medicines, where should I go? These kind of networks that need to develop in the community were something that were raised. Subsequently, of course, we heard about the district mental health program. It started in 1996. There were only about 25 districts in the next 7 or 8 years. But now it is operational in more than 700 districts, 725 districts. That is nearly 90% of the districts. However, the most important thing is that it is very inequitable in terms of the quality of services. But nevertheless, in many states, there is a psychiatrist now available at the district level providing care. And I'll tell you a little bit more about it as we go along. In terms of specialized services, there are psychiatry departments in many medical colleges in the country. There are AIMS now throughout the country with departments of psychiatry. Dr. Murthy mentioned 1,000 seats. So there are a lot of PG seats. I remember about 10 years ago, there were only about 400 seats. So the seats have doubled. And of course, there is a growing private sector of psychiatry. There are professional bodies, psychiatry, psychology, social work, nursing, and so on, all of which are contributing to try and improve the mental health services in the country. The next slide, please. So in terms of innovations, both in the district mental health program, which not only focuses on developing awareness, giving services, providing awareness in schools and colleges, monitoring the policies and so on. In some states, they've actually gone to the taluk level. So that, they, on a one day in the week called Super Tuesday, they go and provide mental health care services at the taluk level. An idea of daycare centers and other rehabilitation centers are also possible under the scheme, under the National Mental Health Program. Some states have done very interesting and innovative programs where they've looked at religious healing and combined it with, providing medication. There are examples from Gujarat, from, other parts of the country, including Karnataka, Tamil Nadu, and so on. There's also been a focus on community-based interventions, and we heard a couple of examples in the World Mental Health Report, but actually taking care to primary health care, trying to help people where they are to access medications, to have follow-up. But these are few and far between, and we only have models, and the scale-up has still not occurred. The use of mobile technology and other tele-interventions is something I will allude to, and that has kind of been fairly transformational in trying to get mental health care to more people. And of course, there are very good examples of NGOs who have been involved in mental health care, maybe about 45 to 50 NGOs throughout the country, which is a very small number, but certainly they have also been involved in increasing the awareness and providing services. There are also user and carer groups, again, very few in number, but it's important that the movement has started. So their engagement also in mental health care development and service delivery becomes very crucial. Next slide, please. The next slide, please. Yeah. So we know that in the Ayushman Bharat, there are 12 packages, and that includes mental health. In fact, the Ayushman Bharat also has an insurance scheme where people with mental illness who are admitted to hospital, who are not able to pay for it, can also have their treatment paid for. There's also the Health and Wellness Center. More than 2 lakh health and wellness centers are expected to be set up, and mental health promotion and treatment of common mental health disorders is possible because of basic counseling and follow-up care there. There are lots of social welfare schemes which people need to be aware of. Disability allowances for people with mental illnesses, various schemes which help to, provide. There's something called the Deen Dayal Divyangan Rehabilitation Scheme, which provides for rehabilitation. There is something called the Scheme for Implementation of the Rights of Persons with Disability Act. Under the National Trust Act for children with intellectual disability, cerebral palsy, and so on, there are a variety of schemes that are available. For children, there are schemes which are available. There are programs like Vatsalya. There are programs for Shakti for women who undergo domestic violence, and there are one-stop centers to help women. And Samvad is a center which looks at children in conflict with the law and trying to educate people so that the children can get the right kind of support and remediation and rehabilitation that they require. So there is a lot happening, but I think awareness about all these schemes is also very poor in the country, and providing access and connectivity to these schemes is also a challenge in the country. Next slide, please. So in 2015, when the Human Rights Report was actually published, we talked about this kind of intersectoral, and it's very nice to see the current World Mental Health Report and look at all the connectivity. So there again, we said that the community care providers, user groups, and advocacy groups and media need to engage along with professionals and academic and researchers, as well as mental health multidisciplinary professionals and government policymakers, as well as the judiciary and human rights institutions, to provide care within the larger community, to have accessible and stepped care for severe mental illness, for people with intellectual impairments, common mental disorders, as well as acute stress. We saw a role for other institutions like medical care, for example, as well as psychiatric institutions and NGOs and community carers to provide a comprehensive care. And it's very nice that now the mental health report looks at also having these kind of things, including the social services. And I think that's very important, that it's not just enough for the health sector to engage, but we need all these other sectors to engage in providing appropriate mental health care to people who need it. Next slide, please. COVID-19 has thrown up many challenges. It certainly increased mental distress. It's increased the amount of mental health conditions that we see. It has further reduced the already stretched access to care. We know that there are long-term neuropsychiatric sequelae that have been described. And unfortunately, there are social downstream events like loss of job and so on, which again can lead to mental health problems. However, it's also provided us opportunities in terms of recognizing the most important thing, which is the human mental health responses to crisis, the importance of well-being and resilience, the importance of empathy, collective responsibility, and caring for one another. And that again is a very important component for mental health. We also have realized that we can have alternatives to face-to-face consultations and that we need an integrated whole of society approach where everybody is involved in looking at mental health care issues. Next slide, please. So I just wanted to tell you that in the COVID, we had a psychosocial helpline run by NIMHANS, which catered to more than 6 lakh people. And, and provided information, support, and various other kinds of services for them. In the country, we also have suicide helplines. We have helplines for tobacco cessation called Tobacco Quit Lines. We have M cessation, where people can just dial for SMS messages to help them to quit tobacco. So there are many kinds of digital interventions that are occurring in the country. Next slide, please. Yeah, so we've been able to leverage technology to what we call the digital academies, which have been set up at NIMHANS, at the LGB Institute in Tezpur and CIP Ranchi. At NIMHANS, we've been able to accredit. Remember, we were talking about human resource shortages. So we've been able to accredit doctors, nurses, psychologists, social workers, and lay counselors in various kinds of digital training programs, diplomas, certificate courses, and even for volunteers in the community, as well as for specialists in addiction, in perinatal psychiatry, rehabilitation, and so on. So this has given us a platform to increase the training and therefore the human resources in the country. The next slide, please. So how do we transform mental health care? As we said, we need to have a developmental perspective from, the unborn child. So perinatal mental health becomes very important. The children and adolescents become very, very important because that's the formative time where they can have a lot of not just, problems related to self-esteem, to confidence building, as well as mental distress, to adults, particularly with a focus on gender-sensitive care. The elderly, again, have a range of mental health problems that they may face. We also know that there is what is called multimorbidity. People with communicable diseases like TB, hepatitis, HIV also have a lot of psychological distress. People with NCDs, the non-communicable diseases, diabetes, heart disease, cancer, respiratory diseases, also have higher rates of depression and anxiety. And depression and anxiety can also increase the risk, and severe mental illness can increase the risk for physical illness. So we need multi-sectoral and intersectoral approaches which combine things. We also discussed the need for mental health care in correctional settings like prisons, in children's homes and old age homes, and so on. We also need to remember that mental health is something that is not cross-sectional. There are many upstream events, like, for example, childhood adversities, psychosocial adversities, which can cause mental health problems later, trauma, which can cause mental health problems. And when you have a mental illness, there can be downstream problems like not being able to work, like having interpersonal difficulties. So we need to look at it in a comprehensive manner when we transform mental health into the public mental health, which involves all of us. Next slide, please. Finally, we need to enhance the resources for mental health, and we've been trying to do that through what is called the ECHO project, through our digital academies, through tele-mental health services. Now we have, since health is a state subject, many of the states have taken ownership and started training their health workforce in basic mental health issues. So hopefully there will be a transformation in mental health care. Finally, I'll just say a word about Telemanas before I wind up. As Dr. Gangadhar mentioned, Telemanas is something that was initiated by the government of India in its budget announcement this year. Next slide, please. And what we envisage Telemanas is that it will become a digital arm of the district mental health program. It will provide services to people who call in for services. It will allow us to have a networking of services. It will allow us to improve capacity at the district mental health program level, at the taluk level, as well as the primary healthcare level. And it will also allow us to have better community-based strategies. And what we do is that we have a person we establish a tele-manas cell in each state and union territory. There are trained counselors who will take the first call, who will provide basic counseling, who will triage patients who are suicidal or who have severe mental illness, are attended to by a mental health care professional or referred to the services in the community. And this is being done with the help of NIMHANS, the IIIT, regional coordinating centers, mentoring institutions within the country, and all the state agencies that are there. So we hope that this treatment gap gets reduced somewhat. But finally, I just wanted to end by saying mental health is everybody's concern. From self-help and taking care of ourselves, we need to expand it to others. We also, is there a next slide? Yeah, so just to say that we also need to integrate various systems, and that's something that we have been doing, not just looking at the conventional allopathic systems, but looking at indigenous systems, using yoga, using other methods, so that we can have a spectrum of services for people to improve their individual and societal mental health, but also to be able to recognize when they need help, whom can they reach out to help, and when there is a diagnosed mental disorder, not to delay, to get help on time. And for people with severe mental illnesses, to make sure that they have their human rights, their dignity, their rights to every possible aspect of living ensured. So that's, I hope, will be a transformational thing for mental health. And the last 3 decades, I just wanted to end with what Dr. Khandelwal said, that it's an exciting time for mental health in the country. And I do hope that we can move towards looking at both improving our mental health as well as helping people with mental health, the problems, in a meaningful manner. Thank you very much for your attention.
Thank you, Professor Murthy, for a very lucid presentation and a very important message for all of us. Thank you very much for your presentation. We have a few minutes now. If there are some questions and brief comments from the audience here. Anybody would like to ask a brief question? Yes, please. हाँ बोलिए आप, मैं बोल दूँ.
So during COVID time, and when we contacted that this NIMHANS helpline, so there was a recorded message. Your call will be recorded for further training. So being a psychologist, check what is. So this is, I think, violation or is not against the law, and anyway it's not going to help, because the person, it is a very personal thing when we are sharing some psychological problem with someone. And the call center,
I can answer this. I can briefly answer this. This is.
Other things, during it was published in newspapers also, mental health care is provided in one of the districts of Delhi. And I just to check, I called it. First of all, the awareness was not there. Madam, ऐसा कुछ भी नहीं है. मैंने कहा please आपने publish किया, देखिए. When it came, आप अपना नाम नंबर नोट करा दीजिए. We will make.
Actually, I have understood this. Look, we cannot manage. We cannot handle all this. The first question which you asked, it's a standard practice that whenever there is a communication with any organization, that there is always a recorded message, that this message or this talk will be recorded for training and for further improvement purposes.
But it is on the part of the client who is asking for some help. He or she may not be able to.
But it remains it remains confidential. Let me assure you. No, we can't go into that argument.
That is it.
May I have any other? Yes, I appreciate your point, but we can't go into this. Yes,
So may I
please.
ask? Sir, I am working as an art therapist and I deal with a lot of anxiety and depressions, and there's a lot of improvement also when we see on one-to-one basis. So might be I can be a bit. So I was saying I'm working as an art therapist and I deal majorly with the children, because learning that these are the formative years and we see the problems we see in the adolescents and the professional, early professions, they are because what they have taken up in their childhood. So I did my research in art therapy, and then I just combined it with the mindfulness to make the series of exercises for
Question,
them.
please.
Yeah, so I just wanted to ask that how we can associate, because we are like, a very small category who are doing this, but how can we associate with the programs what, the esteemed organizations are doing, or if we can be of help. So what is the procedure
I got your question. May I request Professor Pratima Murthy to answer this question? That how the limited number of art therapists who are in the country, how they can be helpful in whatever transformation we are aiming at.
So, I mean, I think there are a lot of different kinds of approaches that we need to look at when we're, for example, helping children. So, while we look at, not just cognitive abilities, emotional abilities, motor skills, and so on. So I think all of this becomes very important. We, for example, have collaborated with some of the NGOs, come together, done some of the art therapy workshop. But I think most importantly, to try and see how this fits in with the rest of the, interventions that need to be done becomes a challenge. And therefore, I think there are so many other different modalities that one can use, but I think one needs to see how you can link them all together in a continuum of services for a person, and at what stage each thing becomes relevant.
Thank you, Professor Murthy. Any other question? Yes, please.
Thank you very much, Professor Murthy.
Can you speak into the mic? Please switch on the mic. Yes.
Okay. Thank you so much. Hello, am I audible?
Yes, you are.
Okay,
yes.
Thank you. Professor Murthy, I really want to thank you about what you told about telemanus, because that is one thing that we can, use that service. I have used the mental health services for various crises of my own life. I have a husband who was an alcoholic for many years, but today he is sober for 21 years, and it is all thanks to the door that I knocked of Dr. Khandelwal at AIMS. I took the courage to go there. In our days, in the mid 80s and late 80s, going to a psychiatrist was like, oh, such a shame, And then I had my mother-in-law who was an Alzheimer's patient, and I was nursing her, and with the result, I became a nervous wreck myself. And again, I had to go to Dr. Khandelwal. My father, he was a dynamic person, brilliant, class 1 officer, and in his mid-40s, he was undergoing a depression. And my mother, she thought that and in those days, we didn't have internet. We used to read encyclopedia. If somebody has become like that, what could be the reason behind it? So I told my mother, I said, there's something wrong with him. We need to go and, see a specialist. So she kept denying, nahi, aisa nahi ho sakta, he's doing so well and all those things. And I think Dr. Khandelwal has been a pillar of strength to me. And I think today I'm a very strong person because I have faced so much, but come out of it. Today our family is united despite the problems that we had. And, my father, he's no more, but he lived a happy life after his treatment, his sittings. My husband is doing well. My mother-in-law is no more, but she lived a good life after we got out and seeked for the mental health services.
I'm so glad that you mentioned what you did, because I think that's the important thing. I think being able to talk about distress, about being able to get help is so important. What you said reminded me of a program I did with a lot of young people who, we just had a small, sit down and get together and got them to talk about times when they had felt that life was not worth living. It was so enlightening and empowering to actually understand how they had been able to struggle with that, how they had been able to reach out for help. And I was just thinking of so many other people who would not have had that opportunity. So I think it's about discussing with each other. It's about being able to get the kind of help, acknowledging it, and being able to share it without any shame. a lot of people feel responsible for the way they are feeling. But to understand that sometimes mental disorders are not their own making, but the fact that they are biopsychosocial problems for which help is available also needs to be recognized.
Thank you.
Thank you
Professor
so much.
Srinivasa Murthy, you have been working a lot with the users of mental health services. Would you like to add something to what the user of mental health services mentioned here? Hello? Professor Murthy?
So you'll have to
Sorry. Sorry, can you just repeat the question? I'm sorry, I missed it.
There was a user of mental health services, I'm not mentioning her name, and she mentioned her predicament about taking help of psychiatric services for her own family members.
Okay.
Professor Pratima Murthy mentioned some, but since you have been working with users of mental services.
Thank you very much. I'm sorry, I missed that because it's song. I think a very big issue, the elephant in the room in mental health, is the focus on patients and not the people. I'm saying this because we have a baggage of deviancy for the last couple of thousands of years, where we have not looked at mental health in a positive manner. Okay, I think it's very important for us to make, I keep giving this example of beauty business. If you set up a beauty parlor and say, all ugly people come to me, no one will come to you. What they do is that they say, use the powder, use the oil, use the lepa, and when you want to be more beautiful for a marriage or something, you come to me. So beauty business, I mean, I saw it from Sushmita Sen's becoming Miss Universe, the change that has occurred. Unfortunately, in mental health, we are still preoccupied with this, not only in India. For example, the T Manas that I heard just now is very much similar to 988, which was started 2 weeks back in America. And already they are getting into problem because even in America, they don't have the resources to the people who reach out to them in terms of services or the mobility. My own personal feeling is we need to do two things. One, more research into self-care and more dissemination. A very good example is our Prime Minister Modi making yoga such a positive thing in the last 7 years, which was known for thousands of years. So I personally feel we are still, even the WHO report 2022 is still too much on services rather than empowering people to take care of themselves. I strongly believe in that. I say that again, that it should be the focus of the next 10 years of work. Thank you.
Thank you, Professor Murthy. Any other question? Yes, please.
Can spirituality, meditation,
You can come here and
yoga be part of the treatment for mental illness?
Meanwhile, a question has come for use of Indian traditional practices like yoga, pranayam. May I ask you, Professor Srinivasa Murthy, you have recently reviewed about the Professor Srinivasa Murthy.
Get the question, Sudhir. Can you just repeat it?
The question was about the Indian traditional practices, yoga and other things, which Pratima Murthy and you mentioned. But I want to specifically focus on spirituality and mental health care.
You know that WHO report 2022 has only one word on spirituality, just one word in the whole report. I've read it page to page, and spirituality is one of the biggest resource that we have. I'm not talking about this, that JAMA just last month had a major paper looking at spirituality in health in general. Those of you who would like to just send me a message, I'll send you the full paper. I think in the COVID period, for example, there was paper from Wuhan showing that people who are spiritual had less mental health effects due to the lockdown and other things. Similarly, those who did exercise, those who had social supports, they all did better. These are not medical intervention, they are psychosocial, spiritual intervention. About a month back, Dr. Akhtar made a very interesting point. There is a bio-psychosocial, spiritual way of understanding. Interventions have to be in all of them. And to me, I strongly believe it because as a cancer survivor and working with cancer people, the spirituality is the resource that is there. For example, now we are working with caregivers of developmental disabilities. Repeatedly, they say it is the spirituality which has been of help to me to deal with the problem. But the question is, we need to disengage it from religion and make it possible to practice it, like forgiveness, gratitude, kindness, rather than saying that we go to the temple or go to the mosque or go to the church. So I think there is a huge amount of resource that is available in the community, which we must activate it so that people can take care of themselves. And that way we will be getting over all the problems that we have been talking about, manpower, stigma, and other things. Thank you very much.
Thank you very much. There was a question coming from this. Yes, please.
Good evening to all the esteemed guests present here. Among all the panelists and all the audiences which are present here, my knowledge as a college student very, very negligible. But my question is one simple question. 3 words were focused: attitude on mental health, the fund to be given, and the approach we are taking. So, the esteemed sir, Professor Srinivasa sir, I liked your very much point that WHO is focusing on the services and not on the attitude, which is actually a biggest point to be focused on. Because unless and until we change the attitude of people of how how to approach one mental condition, mental attitude of basic people, so how are we gonna benefit with the services? So, sir, my question is simple, that as an individual, even though the worldwide there are many surveys conducted, there are many movements being taken place, thanks to Indian government and many panelists and esteemed guests like you, that these services are being taken place, how we as individuals can help in aiding the mental services for people, like as common people, how can we help into it?
Thank you very much. Since you referred to your question to Professor Srinivasa Murthy, I may again come to you, Professor Murthy.
No, thank you very much. The question that I want to, I think it's a very good question. That's a very practical question. Last 2 years, I've been working with caregivers of developmental disabilities. I just want to tell you 2 or 3 things about them. Firstly, during the COVID, we called them up, administered WHO questionnaire, SRQ, self-reporting questionnaire, found more than 60-70% were above the cutoff point. And we said that Dr. Murthy is available, call us up. And we found that hardly anyone called up. So we went back to the drawing board, looked at the evidence, and identified 5 things which are evidence-proven: exercise, sleep, nutrition, yoga, meditation, connectedness. 5 things which can strengthen people, and there is evidence for that. Then we identified 5 other things: sharing of feelings, journaling, doing pleasurable things, thinking differently, and spirituality. We converted all of this into a practical 1-day program from 10 o'clock to 4 o'clock. And all of this is available both as written material, videos. So anyone can strengthen themselves, handle their day-to-day distress without having to call up a phone number or going to a psychiatrist. And I'm just putting my email on the question answer one, which is open to everyone. Please send a message to me. I'll be happy to share all of these things with all of the people. Thank you.
Thank you, Professor Murthy. I think I will not take any more questions. It's a lot of time has gone into. Thank you for your attention. May I ask Professor Dr. Bruni for his comments? You have heard all the presentations. You have heard some comments and some questions. So I would like to ask you that if you wish to add something on what has transpired in the evening.
Thank you very much. Yeah, let me comment quickly on this final aspect, whether what matters is attitude or services. I think it's quite obvious to me that it's both, and that attitude matters a lot, and WHO is very much aware of this. If you just think, for example, of probably the most widely implemented program of WHO in mental health, which is the mental health gap program, MHGAP. There is an entire section at the beginning of the intervention guide, which you can download easily on internet and also as an app on your smartphone, which is essential care and practices, where you have very basic general principles on how to relate to people that in a way or another are experiencing some form of suffering, how to communicate with them, what are the do's and don'ts, how to show respect, and so on and so forth. So we know that all of this is the basis for mental health. So WHO is very much aware of it. On the other hand, I was listening to this interesting conversation with a little bit of worries about the idea that we don't really need services, because that is basically giving all responsibility on people, on individuals that are suffering, on their family members, on the communities, and that can be extremely dangerous. I think we advocate, in fact, for scaling up services in mental health. Definitely. We have been seeing from all these reports that very often mental health services are not enough developed, are not enough funded, are not enough resourced. There's not enough human resources working there. So there is definitely need for scaling up services. And back to the first comment from the participant who kindly shared with us her own experience. Establishing mental health services based in the community also helps reduce stigma. We are well aware that the stigma which is associated to psychiatric institutions is huge. And when mental health is worked in the community, including in primary healthcare, where all sorts of physical conditions are being treated, detected, followed up, and so on and so forth, then mental health becomes something much more accessible on one hand, but also less stigmatizing. Thank you very much.
No, sir. Koushik? Atul, though you talked to us about the drug use, but looking at all the presentations and especially talking about the transformation of mental health services, because you are basically a psychiatrist, you wish to add something which would be useful to the audience.
So basically, the point which I think the people who are non-professionals also understand very well about being able to empathize. I think that's a very human quality. You don't need to be a mental health professional to understand the importance of it. And as we heard from the members of the audience as well as experts also, the importance of change in attitudes. So I think besides stressing upon improvement in services, the community mental health programs in terms of more health promotion, I think is the need of the hour. And I totally agree with, and it's a lesson from Dr. Murthy also for us, that perhaps next decade should be spent more in developing these community-based resources. Thank you, sir.
Thank you, Atul. Now it's the time to wind it up and expressing my thanks and gratitude. First of all, my thanks to all the audiences who have present here physically and also who have joined us online through Zoom or the YouTube. And I wish to extend my profuse gratitude and thanks to all the panelists, Professor Srinivasa Murthy, Professor Pratima Murthy, Dr. Andrea Bruni, Professor Atul Ambekar, and Dr. Koushik Sinha. You have really done a remarkable job, excellent presentations, and making things very clear to all of us. I wish to express my thanks to the India International Center, to its director, who readily agreed to my proposal for this discussion, and to Miss To Chang, the Chief of Program Division, who kept up with all the demands and the requests which I made over last 2 weeks, bombarding her with messages and emails, and I must admire that she did a very impressive job responding to mails, sending the links to all the panelists, and keeping us informed about the way the entire evening will unfold. And also, of course, to her IT team, and some of them are still present. Thank you very much. I wish to say it personally for your very dedicated and commendable job, and also to the catering services for providing us with tea and coffee and cookies. So thank you once again to all of you, and to all of you that you sat here throughout the evening and listening to all these presentations and discussions very patiently. Thank you. Thank you very much.
Yeah.
Sure.